Now, I've got the pleasure of introducing our speaker for tonight, who's Dr. Melanie Fentoullis, and she's a consultant general paediatrician and a senior lecturer in the Faculty of Medicine at the University of New South Wales. She's currently working in private practice and as a paediatrician at the Royal Prince Alfred Hospital, in addition to her work as a senior lecturer at the University of New South Wales. Her particular interests include newborn and infant health, including navigating the challenges of feeding, sleeping and settling, supporting healthy growth and nutrition, including children above a healthy weight, and also allergy. So welcome, Melanie. Thank you for joining us tonight. We're really keen to learn a lot more about early or precocious puberty.
Fantastic. So I'll just double check you can hear me and see the presentation. Great, excellent.
Yes, we can.
So
Absolutely.
Thanks, Margot, for that introduction. So yes, so I work as a general paediatrician, as a VMO at RPA and in Rooms, and as a senior lecturer at UNSW. And it's a pleasure to be able to talk to you today. Unfortunately, I can't see all your faces. I'll just, hang on, I'll see if I can flick through my screen. Okay, so in my practice, as it would be in your practice, early pubertal development can be quite a common cause of parental anxiety and something that we quite commonly see. It's also something that I've found often comes up as an incidental finding on an otherwise well child, and I can only think in the last 6 to 12 months of 2 children that I'd seen for unrelated reasons. So a child with delayed walking that had some breast development associated with premature THELARCHE, and then a well child check that I did, and it was a young girl who was above a healthy weight who had some pubic hair development. So you know, these concerns are quite a common reason for referral to paediatric endocrinologists, and overall, or overarchingly, early or precocious puberty includes a number of benign variants of normal development, as was the case for the 2 patients that I spoke about. But there are, you know, a small number of children who do have pathologic conditions, and unfortunately that's associated with some morbidity and sometimes mortality, as with the, you know, the MRI scan that you can see here with a hematoma around the hypothalamus, of the hypothalamus. So in terms of learning outcomes, I really want it to be practical tips. So I really understand and admire your ability as primary care physicians to work with such significant time restraints. So I really want to portray a number of key points, and I've put them through my presentation, really highlighting what's essential in terms of clinical assessment, what can't you get away with not doing, and what are the red flags. So once you've identified a child who does actually have early or precocious puberty, what are the red flags in terms of identifying that the child that actually has a pathological cause that needs urgent coordination of investigations and referral. I also want to highlight some key points around the psychosocial impact of puberty, but also early puberty, and thinking about that as part of the management, because that's where I really see our role in terms of working with the endocrinologist, is really supporting the child and their family and the psychosocial impacts that puberty has on all children, but in particular when it occurs in younger children and at in a precocious puberty setting. Okay, so you know, what do we actually need to know in terms of basic physiology and basic physical changes to answer some key questions and recognise those red flags? So So in terms of physiology, we really need, oh sorry, I'll just run through actually those questions again. So the key considerations, sorry guys. Okay, so the key considerations of, or the questions that we're trying to answer are really, you know, is this child an early maturer, or so someone that's within the normal range, but their puberty milestones are occurring in the early stages of that normal range? Or is this a child who, yes, actually fits the definition of being too young to have actually reached that specific pubertal milestone, and is outside that normal range? We then need to understand the hormonal changes, because that actually helps us identify in those children that are too young, what's the cause? So what, you know, understanding the hormonal changes that helps us elicit the cause. And then, as I said, thinking about the not just the medical treatment, but our role in terms of supporting the psychological changes and impacts that puberty has on our patients. So what are the hormonal changes that happen? So, you know, puberty is triggered by the hypothalamus, which begins to have pulsatile secretion and release of the GnRH hormone that then stimulates your follicle stimulating hormone, so FSH, and luteinizing hormone. I won't go through this in too much more detail, but LH really stimulates the ovaries to secrete estradiol and the testes to secrete testosterone. So they're your gonadal sex hormones. Now, the physical changes of puberty are related to the gonadal sex hormones that are produced, and it's that activation of the hypothalamic pituitary gonadal axis that we call gonarchy, and gonarchy is pubertal onset. So I guess, why do we need to know this? Well, estradiol produces progressive breast development. So estradiol produces progressive breast development, and importantly, the pubertal growth spurt, so rapid bone age advancement. And then testosterone causes the penile enlargement, pubic hair growth in boys, and then by conversion of to estradiol then also causes the male growth spurt. In terms of other features of puberty, so mild acne, pubic hair in girls, and the adult axillary hair odor in boys and girls is related to weak adrenal androgen secretion. So this is actually referred to adrenarche as adrenarche. Adrenarche is a separate but a concurrent process, so it's unrelated to activation of the HPG axis. It doesn't actually itself indicate true pubertal onset in boys and girls, so it's a concurrent process. So I've put these here just as a reference. Oh, sorry, I'm just realizing my slides are just a bit out of sync into what I'm speaking. Sorry. So I won't run through these, but these are the specific components of puberty and the hormones responsible for those physical changes, being the adrenal and the gonadal sex hormones. Okay, so what actually is early? So there are a number of recent studies and data that have highlighted that there are ethnic and racial differences in the terms of the timing of puberty and puberty onset, and also some observations that overweight children, in particular girls, undergo earlier breast and pubic hair development, and somewhat earlier menarche than do girls of normal weight. So in some US studies, the glandular breast development was occurring in girls of 7 to 8 years of age in approximately 10 to 23%, depending on the ethnicity, ethnic background of the patients that you were reviewing in that survey. So we do need to, particularly in girls, take into consideration their BMI and their race and ethnicity, but a really reasonable cutoff for considering referral in girls is definitely before, so pubertal onset or secondary sexual characteristics that are identified before the age of 8, and then being aware that true precocious puberty is about 20 times more common in girls, and for the majority of cases in girls, the cause is actually idiopathic or unknown. It has to be remembered that pathology actually is much more common in boys, so our cutoff in boys is higher. So any pubertal or secondary sexual characteristics that are identified before 9 years of age in boys should definitely be fully evaluated and referral considered. In both cases, so both boys and girls, your level of concern and your extent of evaluation always increases with decreasing age at presentation. So if you had a 6-year-old girl or a 4-year-old boy, you're much more worried about a pathological cause. Okay. So I've just popped that up as the key point. So evaluate and or consider referral of all girls 8 years or younger. There's much more frequent pathology in boys, so evaluate and refer all boys younger than 9 years. So in addition to this broad cutoff, because in paediatrics we love normal ranges and we love centiles, there are actually centiles and normal ranges for each specific secondary sexual characteristic. And having these actually allows us to not only monitor the onset of puberty, but also the sequence of the pubertal milestones and to see whether or not they're occurring in the expected sequence. and also the tempo, so the progression of these changes to see whether or not there's a normal tempo or it's quite rapid progression, which would heighten our level of concern about pathology. So we need to obviously first know how to identify these secondary sexual characteristics, and then we use maturity rating scales such as the Tanner stages to then put them into the centiles. So for girls, there are specific changes related to breast, pubic hair and development and menarche, and in boys, penile and testis development and pubic hair development. So because we're not expected to know where the normal ranges and centiles are off the top of our heads, I just wanted to put a link about where you can find these. So they're freely available at this website, so the Australian Paediatric Endocrine Group. If you search for their growth charts, you can click on the growth charts for girls and boys between 2 and 18. You then can, if you wanted to print those out, you can print them out in your rooms. At the back page, there's also some information about how to order them, and they can be delivered to your room so you can have them available. At the back page of these growth charts, you have all the descriptions of all the Tanner stages for all the different sexual maturity rating scales for genital development, pubic hair development, and breast development. So what does that mean? So on page 2 of the growth charts, which is the height centiles, right at the bottom right-hand corner, there's actually the centiles for each of those pubertal stages. And again, that allows you to visualize the onset and the sequence and the tempo. So really, you're trying to decide, is this too early? Is it occurring in the normal sequence that we would expect? And is the rate of change or the development progressing too quickly? So I'll show you. So that's the one for girls, and that's the one for boys, just zoomed in. So looking in more detail at these changes, for instance, a girl who had breast development beginning, and that was so stage 2 breast development, they have a mean age, so girls have a mean age of stage 2 breast development of 10 years of age. So you can see the 50th centile for stage 2 plus is just less than 11, but 10 years of age. And the normal range is from 8 to 12 years. So menarche often follows about 2.5 years after the onset of breast development. So for that child in the 50th centile, that would then be about 12.5 years of age. For boys, testicular enlargement or testicular volume is classically measured with an oxidometer. I'm not obviously expecting you to have an oxidometer in your rooms, but the first true sign of puberty is testicular enlargement to at least 4 mils. And if you don't have an oxidometer in your rooms, 4 mils is approximately 2.5 centimeters in length. So that's quite a good resource about how to measure testicular volume, but the 4 mil measurement on the oxidometer is about 2.5 centimeters in length. So where does that fall in the centile charts? So that occurs around 11.5 years of age as the mean age, and then the range is about 9.5 to 14 years, so approximately 14 years. So for pubic hair development, the first sign of pubic hair or stage 2 pubic hair development occurs in the early mature for boys, around 10 years of age, and for the late mature, around 14 years of age. So the reason I included that here, so the early mature is still within the normal range, and the late mature is still within the normal range. So when you fall outside of the normal range, that's when you have early or precocious puberty. The other thing I wanted to highlight, that although my topic's about early puberty, you can definitely use these charts for identifying late developers or delayed puberty. And then the average for this age group, so for boys is around 12 years for stage 2 pubic hair development. All right, so just a little case that I made up this one, but your next patient's Sophia. She's 10, she just turned 10 last month. And her mum brings her in because she's worried about some possible vaginal bleeding and is worried that this is her first period and, you know, is this too young? Her mum lets you know that she's actually been quite self-conscious recently about changing the public toilets for her swimming classes, pre-COVID swimming classes. And that's happened over the last 6 to 12 months and she thinks that's the case because she's developed some pubic hair. and she feels a little bit different from her peers. So you examine her as part of your examination and you assess her breast development. And after attending this webinar, you recall that, and you're a bit reassured by the definition of early puberty as the appearance of secondary sexual characteristics in a girl who's less than 8. So you stage her breasts and find that they're stage 2. And then when you look at the chart, reviewing the centile charts, these findings indicate that she has early puberty because of, I guess I've just given you a couple of options, but looking through those options, thinking about the features that we've described, which one of those options would be the sign of early puberty. So I don't have all of you to contribute, but her breast development was 2+. Her possible pubic hair development was within the last 6 to 12 months, but her menarche was a month. She was about a month ago, or within the last month, she had onset of menarche. So my answer would be C. So although she fits within the, I guess, normal range for that general definition that we provided earlier, her menarche is occurring almost out of sequence compared to what you would expect, and also is early compared to what you would expect in terms of the centiles. So my key point here is know the physical changes of puberty and have the tools such as these centile charts that are freely available to identify who is actually an early maturer, so early normal range development, as opposed to the red flag, so who is actually having signs of puberty that are too early and that warrants further evaluation and referral. These charts also, in terms of key points, allow you to, as I said, identify the sequence of pubertal development, because when it's truly precocious puberty, this can also provide a clue in terms of whether or not, in terms of the cause, so whether or not it's central or a peripheral cause. So often children who have central precocious puberty, so related to so LH and FSH production, that is generally, so central activation of the gonadotropins, it usually follows the normal pubertal development sequence. So, you know, you have testicular enlargement in boys, that's then followed by penile growth, that's then followed by pubic hair growth in boys. Peripheral sources of gonadal hormones, so there's sex hormone production either by the adrenal gland or by the gonads themselves, or a tumour that's producing sex hormones, that's more likely to have pubertal developmental sequence out of deviating from the normal sequence. So that might be something like breast development, but no pubic hair development. These charts, another key point is that they allow you to have a feel for the tempo of the changes. So rapid progression is a red flag. And how do I define rapid progression? So I'll define slow progression first. So slow progression is what I would say is minimal or no changes in the stage of development, so breast or pubic hair or genital development during a period of 6 months observation. So anything more rapid than that is rapid progression and warrants further evaluation and referral. Growth and puberty are growth and puberty are intricately linked, in particular linear growth, so height. So in addition to that, we'll run through that in the next few slides, but rapid progression of the pubertal milestones in addition to growth acceleration. So rapid growth, again, is a significant red flag to warrant referral. So over the next few slides, we're going to run through understanding the relationship between puberty and linear growth. And if I can give you one message to take home, this is it. So definitely measurement of growth is one of the key clinical assessment tools you have to identify children with pathology. So in terms of prepubertal or normal linear growth, this is quite reassuring of a benign cause. Whereas abnormal linear growth or rapid linear growth, so evidence of growth acceleration, so we're thinking the pubertal growth spurt is happening earlier, definitely warrants further evaluation. So how do you do this accurately? So I'm not going to talk to you about how you measure heights, and but there are resources out there. So I've put the website for Pro Healthy Kids, which is a website more for children above a healthy weight, but how to measure height and length accurately in your rooms. And in the COVID environment, there's also some resources out there for parents so that you can actually get them to measure their height accurately at home while you do a telehealth consult. So what is the relationship between growth velocity and height percentiles? So again, referring back to those APEG growth charts, the height velocity is on the very first page. And in order to grow along a height centile and maintain that height centile, your height velocity, so how fast you are growing in centimetres per year, needs to be maintained on the 50th centile for height velocity. So that's how you track along a centile. So for instance, I plotted some values for a child growing along the 25th centile. For that child to maintain their height growing along the 25th centile, their growth velocity has to be approximately around the 50th centile when you're measuring it in centimetres per year. So how much do children actually grow? So in the prepubertal growth years, before their growth spurt, they're growing approximately 5 centimetres a year. They then have a little nadir before their pubertal growth spurt. So the centiles on the height velocity chart are in black, and they're for children who are, their puberty is progressing along the 50th centile. So, you know, pubic hair development, breast development, testicular growth, all of those milestones are around the 50th centile. That's the black lines in this height velocity chart. So if you are using the 50th centile of those black lines, then the growth spurt or peak height velocity, the mean of that is happening around happening around 11 to 12 years of age. And at that time, they're growing about 8.5 centimetres per year. Girls will achieve their peak height velocity around the time that their Tanner stages are around 2 to 3, and that's before menarche. So bear that in mind. So once girls actually hit menarche, their I guess the growth potential is not very much once they've had their period. So girls complete linear growth approximately 2.5 years after they have their first period. Okay. On this chart is also a little green line, which is the 50th centile for children that are in the normal range for pubertal development, but are in the earlier, I guess the early category, so early normal range rather than precocious puberty. And you can see that they've marked out the 97th centile. So a child whose height velocity is above the 97th centile is very concerning for a pathological cause. So what we want is to understand the relationship between puberty and linear growth, and understand that plotting a child's linear growth, so height or length in the very young, is extremely important in terms of identifying pathology. You may not be doing height velocities in your rooms, but you know, height velocity needs, you know, progressive growth, at least sort of 6 to 12 month intervals. But you can see if a child's height is crossing centiles upwards, then you know that their height velocity is increasing, and that definitely warrants evaluation and referral. So why is this important? So when we're just thinking about the hormones, so estradiol is driving that pubertal growth spurt and the rapid bone age advancement. So there's definitely abnormal amounts of hormone being produced. Okay. Okay. So I'm going to run through a few of the benign or non-progressive pubertal variants, just as some examples. So the first question I have for you is this true breast development? So one of the things I'm going to highlight is that physical examination is key. So in children who are above a healthy weight, we can often, I guess, visualize, particularly when they're sitting, what looks to be breast development that is actually adipose tissue or lipomastia. So you actually, to be more accurate, you need to palpate or examine the breast, which is best done with a child supine, to be actually able to differentiate between adipose tissue and glandular breast tissue. I think even endocrinologists may find this difficult. I've heard of some people organising ultrasounds to make it more helpful, but again, I think it really comes down to physical examination and being able to identify underneath the areola the dense glandular tissue of the breast, rather than the fatty adipose tissue that you might feel in a child that's overweight or obese. Again, in these children, you're definitely going to be observing the progression, and observation of a period of, say, 4 to 6 months, which doesn't show any changes, is obviously reassuring. So premature thelarche, sorry, the slide is very small. I can see the text on that slide is quite small. So premature thelarche or premature breast development is actually quite a common but self-limiting condition. You can have unilateral or bilateral breast development in these girls, and typically it occurs in girls younger than 2 to 3 years of age. The important thing to highlight, as I mentioned before, is that there are no other secondary sexual characteristics present. So this is an isolated finding. You don't have any other signs of estrogen effects on the body. The other thing, again, is key, is their growth, or their linear growth, is prepubertal. It's normal. It's tracking along their height centile. Their height velocity or their growth is not accelerating. So that's really important. If you were to do investigations in this age group, you would probably have a normal or near normal bone age if you were to do an X-ray to assess their bone age. And if you were to do their LH or FSH, it would be prepubertal, but noting that in this age group, there is a transient mini puberty of infancy where you do get a surge of LH levels. So you may actually, if you did do bloods in this age group, you may actually falsely diagnose precocious puberty or central precocious puberty. So in these children, it's really important to assess for other signs of puberty. If you find other signs of puberty, that warrants further investigation and definitely warrants referral. If you are assessing these children and there's abnormal growth that's accelerating, again, that definitely warrants investigation and referral. But in other cases, I would be monitoring these children clinically. The breast size might actually fluctuate, so may slightly change at sort of monthly or 6-weekly intervals, but it typically doesn't progress beyond Tanner 3 stage. And in these children, the timing of all the other pubertal milestones is as per normal. The other thing to mention is it's, again, really important that these children are continued to be monitored, because this actually may, even without growth acceleration and without other signs of puberty, may actually be the initial presentation of a child with central precocious puberty. So you still need to continue to monitor these children, and if there's any change, then obviously prompt evaluation and referral. Otherwise, most of these children need no treatment, and there's spontaneous resolution within about 1 to 2 years. And if parents do ask you, their growth and their final height is not affected, and puberty otherwise occurs within the normal range or normal timing. So I'll give you another case. So a 7-year-old girl comes to your rooms and she's got some blood stain discharged after riding her bike. She often complains of a bit of vaginal pain that parents tell you that often wakes her up at night. So when you examine her, examination is otherwise normal, and you note that she's got prepubertal or stage 1 breast development. So this is a case of prepubertal potentially vaginal bleeding, and it's a much less common scenario than the premature thelarche. So in these cases, it's really important to consider, it's really important to exclude and consider your differentials. So local causes of bleeding. So if it's a child that's had 1 or 2 episodes of bleeding, is this actually hematuria? Or is it a child that's got terrible excoriation because of vulvovaginitis, or excoriation because of threadworm? So waking up in the middle of the night with vaginal pain or itch is really, very suspicious of threadworms. Or has there been a traumatic injury, Or is there a foreign body as well within the vagina? So, you know, a lot of rarer causes, but something that warrants thinking about. So are you going to do a UA? Are you going to treat for worms? Are you going to examine for a traumatic injury? And I think those sorts of things are really important to do before putting this down to premature menarche on its own. The other thing that's really important is to make sure when you're examining the child that there's no other signs of secondary sexual characteristics. And again, their growth. So in terms of children that have premature menarche, again, most will have resolution within sort of 1 to 6 episodes. If it's true premature menarche, resolution after 1 to 6 episodes of bleeding. We don't actually know the etiology, but we think maybe that sort of early on in puberty, the endometrium is quite sensitive to estrogen, and the sort of circulating estrogens have some effect on that, and there's a little bit of sort of transient stimulation by the hypothalamus and the pituitary gland. If you do a pelvic ultrasound, the ovaries are normal, and if you do measure the gonadotropins, they are prepubertal. Again, I mean, in this case, I think given that it's a rarer presentation, you may have a lower threshold to do those investigations to exclude pathology, or even, I guess, liaising or discussing with your specialist, endocrinologist or paediatrician. One of the reasons to definitely refer, though, is if the bleeding is heavy, recurrent or continuous. So that you may refer to an endocrinologist, but depending on the age of the child, a gynecologist or a urologist might be also appropriate. Again, I'm going to highlight combined pubertal changes. So vaginal bleeding with breast development is completely different. You definitely would be evaluating and referring that child. All right, so the other benign variant is premature adrenarche. So again, this is another self-limiting condition, typically children between the age of 6 to 9, and it happens in both boys and girls. You've got isolated signs of puberty, so of the adrenal hormones, so pubic and axillary hair development, body odor, sweating, mild acne. So pubic hair remains, so if the parents do ask, the pubic hair will remain, it's not going to regress, and it will remain until all of the rest of pubertal development is complete. But the rest of pubertal development, those other milestones, are going to occur at the appropriate ages. The rate of appearance of those other milestones, again, is at the normal rate. So normal sequence and normal rate. If you look at their growth velocity, just to confuse things, is usually normal but can be slightly increased. And in these kids, again, I have a slightly lower threshold to do bone age and further investigations. And what you might find is that there is some variation, there is some acceleration in their bone age, so even up to 2 years advanced. The reason I do investigations is that I don't want to miss the rare cause of a child who has congenital adrenal hyperplasia or a delayed presentation of that. And when you do investigations and it's premature adrenarche, you might have a very mildly only elevated DHEAS hormone, but all your other all your other hormones are at prepubertal concentrations. So LH, FSH, with 17-OHP, which helps you diagnose congenital adrenal hyperplasia, and your estradiol and your testosterone levels are at prepubertal levels. So in these children, again, surveillance and monitoring is key, and re-evaluating them at 3 to 6 monthly intervals. Again, looking at progression of pubertal development and their growth velocity is important. Otherwise, once you've diagnosed premature adrenarche, no treatment's necessary, but there is one thing to warn the parents, and it's really important to warn the parents, particularly for girls, is that premature adrenarche can be, not particularly for girls, but for girls, that can be associated with a later onset of PCOS. So particularly if the girl, comes to you, they're overweight, they've got premature adrenarche, you need to optimize their health moving into those adolescent years. Okay, so just one key point to put up there. So with these benign pubertal variants, once you've diagnosed those, you continually need to monitor these children in case, again, it's an initial presentation of true pathology. So watching pubertal progression and watching for growth acceleration is really important. So again, this is a real case of one of the endocrinologists in my rooms who kindly provided me with some cases to highlight some of these points. So this was a 4-year-old boy who came with body odor, pubic hair, and of course with puberty you have increasing challenging behaviour. So the emotional and psychological development that comes with puberty. So on examination, he had mild acne, Tanner stage 2 pubic hair, and his testicular volume was 8 mils bilaterally. So remembering 4 mils is the beginning of puberty, 2.5 centimetres in length. His height was plotted, and over the last 6 months he went from the 75th to above the 97th centile. His weight really wasn't changed very much, and his BMI wasn't changed very much. And as part of the workup, his blood pressure was done and he was normotensive, and there was some hyperpigmentation noted in his palmar creases and his scrotum. So again, this case is highlighting some of the red flags that we've already talked about. So yes, it's reassuring in these cases where linear growth is prepubertal, it's an isolated change. But once you start to get combined changes, so pubic hair with acne and testicular enlargement and growth acceleration, these are all red flags for further evaluation and referral. Okay, so I'm not going to run through, we've covered a lot of the initial assessment. I'm not going to run through in more detail the history and examination, but I've put that there for your reference later of some of the questions that I think are really important to ask. But one in particular is key, and I've popped a really lovely table about the questions and examination findings and the relevance in terms of diagnosis. But one important one that I really want you not to miss, and I don't expect you to miss, but the neurological symptoms are really important. So a child that has any neurological symptoms would warrant further investigation and referral, and what I mean by that is an MRI scan of their brain. So abnormal neurology, red flag. Again, not that you would necessarily be ordering the MRI scan, but just as a note of something sort of interesting to note, if you are ordering them, you do specifically need to ask the radiologist to do pituitary views of their of the pituitary gland. They're, I think, thinner or smaller slices to be able to not miss pathology. So it's something just to put on the form if you do happen to be ordering that test. But again, I think it would be in consultation with your endocrinologist. So again, in terms of laboratory testing or further testing, so once you've done your history and your physical examination, thinking about which of those tests are appropriate as first line, and then ones sort of to order if clinically indicated. So in terms of first line hormonal testing, you're looking at the so central hormones, so your LH and your FSH, and having a look to see whether or not they're at prepubertal levels, to think about sort of benign variants, or whether or not they're at post-pubertal levels. And then you're looking peripherally at your sex, so your gonadal sex hormones, so serum estradiol and serum testosterone levels. Again, thinking about whether or not they're elevated, which could be centrally being driven, or it could be from a peripheral source, as we mentioned before, so from the gonads themselves, adrenal glands, or from a tumour or exogenous source. So a medication, for instance, might be driving that process. So the other investigations to think about are the ones that are sort of clinically relevant depending on the presentation of the child. So for instance, the presentation of the child that we described before with the signs of puberty, are we going to do a 17-OHP, a DHEAS to look for those adrenal hormones and rule out disorders such as congenital adrenal hyperplasia? Do you have signs of thyroid disease, and in that case measuring the TSH and the free thyroxine is going to be important. So moving on from laboratory tests, there are imaging that you might consider. Again, first line imaging might be something like a bone age X-ray to look at whether or not the bone age is advanced. Remember, estradiol is driving that process, so if estradiol levels are high or post-pubertal levels, then your bone age will be becoming advanced. And then, as indicated, whether or not there's neurological findings, if you're thinking about an MRI of the brain and the pituitary, If you're worried about a tumour, so adrenal, so abdominal pelvic ultrasound, so adrenal tumours or pelvic tumours, the other thoughts in terms of imaging. Okay, just a few notes in terms of the investigations. So if you're ordering hormone investigations, please put on the form to do them in the early hours of the morning, which means pre-9 AM. You have a peak in all your levels that occurs in the early hours of the morning. So if, for instance, you have your bloods done at 4 o'clock in the afternoon, yes, you might diagnose pathology with the LH and the FSH being high at that time, but you will miss pathology if it's not raised. And so the peak early morning, so any endocrine tests, any endocrine hormone tests you're doing for any context, please order them pre-9 AM as early morning tests so you don't miss pathology. Okay, another special note just in terms of the bone age. So again, you may not necessarily be ordering that test, but traditionally in children above 2 years of age, it's a left-hand X-ray that they look at the epiphyses and compare to age referenced normal appearances. In a child less than 2 years of age, the bone age is of the knees. They take X-rays of the knees. Now, I think you have to just remember that if you are ordering this test, to interpret with caution. I would recommend an experienced radiologist, particularly in sort of less than 2 to 3 age group, someone experienced, so one of the children's hospital radiologists, or talking to one of the endocrinologists about interpretation, as they can be difficult to interpret. And again, just for completeness in terms of investigations, I popped up that key point again about the MRI. And so MRI scans, again, just remembering one key feature is that although, in all boys that have puberty or signs of puberty in the less than 9 years, that higher risk of having pathology means that an MRI of the brain would be indicated. Any child that has neurology, again, MRI is indicated. And then in the girls, it's a little bit more controversial, but under 6 years, it's indicated. In the 6 to 8 year age group, it really varies. And often what I found is it's, a shared decision made between the parent's family and the endocrinologist, weighing up the risks of IV contrast, the risks of sedation, and the risks of needing sort of follow-up scans when the likelihood of having pathology is quite low in that age group. But again, I think in this case you're going to be liaising with the specialists in terms of making that decision. All right, so again, I think it's important to have some perspective on the treatment, but once you get to this stage, the treatment or the specialised treatment is really in the hands of the endocrinologists. Or depending on the pathology, other specialists. From my perspective, I think it's really important to see what our role is, which is supporting the family and the child through that, the physical and emotional and psychosocial impacts of puberty, which is stressful when it happens in the normal age group as opposed to a really young child. So in terms of true precocious puberty, we classify that in terms of the pathological location. So once you've identified a child that has true precocious puberty, the treatment, as I said, becomes subspecialized and you start to think about treating the cause. Again, thinking about the fact that it's 20 times more common in girls, but for most girls, it's going to be idiopathic. By far and wide, it's going to be idiopathic. But for most boys, it's pathological. So again, that's sort of driving your red flags in your head. For the idiopathic central precocious puberty, once you start thinking about treatment decisions, you're starting to think about adult height and also the psychosocial impact. So that's not treating the cause, but that's thinking about the impacts of entering puberty at an earlier age. So that's what I've outlined on this slide. So many of the cases of idiopathic early puberty, you actually don't need treatment at all, especially if puberty is progressing slowly, and treatment really is around explanation and supportive counselling. The treatments may include gonadotropin releasing hormone analogues. And again, this is out of my area of expertise, so really in the hands of the endocrinologists. But what they're considering is really that the child with early or true precocious puberty now might be taller than all their peers. And this increase in height is due to the premature growth spurt and that the bone age is actually advanced. But bone age, when you actually measure the bone age, that actually tells you how much time that child has left for remaining growth to happen, and it allows you to predict their final adult height. So although the child is tall now, he or she may actually end up being quite a bit shorter than the expected height for their age due to premature fusion of the long bones. So they actually have reduced time to the end of the growing period, and that's an important treatment consideration. Remembering as well, just out of interest, so remembering on those charts, once a girl gets puberty, really she's got about 2.5 years before the end, so before she stops growing. And in that time, they usually, I think it's about 7 centimeters potentially that you may grow as a girl, but you really don't have much time left to grow. Then I think this is really important, is to think about the psychosocial impacts and the treatment considerations. So the endocrinologists have those medications available to them to use, and it might not be discussions with the family about growth potential, but it might be the psychosocial impact that's driving the treatment decision. So obviously children get maybe extremely distressed if they're different from their peers, and puberty is associated not only with being different like physical changes, but a lot of emotional changes as well, and can cause great emotional distress. And going through puberty is difficult enough when it happens in the usual range, as opposed to a child who developmentally is younger. So early puberty might also be associated, with all of those emotional changes come with behavioural problems, and that actually can impact on concentration and learning, and also this ability to socialise in the school environment. So all of that can impact on treatment decision. So again, I want you to think about puberty as a developmental stage, and thinking about psychosocial maturation as part of that. Again, this is a disorder of puberty that can profoundly impact on a child's not only physical but psychosocial well-being. The child, again, might be taller now, and people might treat that child differently as if they're older when they actually aren't. It's only because they're taller that they might be larger, not actually appear older, but developmentally they're not. So you have to think about explaining that to the family, and also having the family explain that to other people who might be interacting with that child, so their school teacher and other things. And the child actually then, because of all the changes that are happening, might actually show a bit more awareness of their sexual parts, and things like masturbation might occur, and that might create embarrassment in other adults and also confusion in the child. So that's something important to address with the family. There might be just changes in the usual routine, so antiperspirants or more frequent bathing needing to be occurring in the day-to-day routine because of body odor and sweating. The child, no child wants to feel or look different to other children their age. So it's really, really important to recognise that low self-esteem can occur. They might be feeling embarrassed about the physical changes of puberty, and it's really important to address this with the child and emphasise as best as possible that their body is normal, and encourage participation in all their usual social or extracurricular or physical activities. It's really important that they stay nice and healthy. So what's out there to help you have those discussions with the family and to support the family? So there's a number of resources, and I've included the links to these resources. So when things are tracking normally, the Raising Children Network has some really great resources about talking to children about puberty. It also has some great links to pages about when it's happening early or late that I would love you all to refer to and refer your families to. When you do have children that do have been diagnosed with either the benign variants or the true precocious puberty, the APEG group have some patient and family booklets. One of them is this one, which is Puberty and Its Problems, which outlines, in in very appropriate detail for your families, explanations of all the hormones, the physical changes, and a lot of the social impacts and strategies to manage that, and also some, lovely question and answer sections. So I've popped that. So first of all, the AP booklet, I put the link in, but as you can see, just an example page, how do I explain precocious puberty to a child? What should, friends and relatives and teachers be told, and just running through some practical tips. And I think that really helps guide that discussion. So again, the Raising Children Network has some really great resources for families to understand the physical changes, understand how to explain that to your children or their children. These are for children within the normal ranges, but I think it's useful to have that information out there. I think trying to be a little bit creative in my mind, one of the resources that I think is quite useful here is their tab for children that have developmental disabilities, so or autism. So they have one specific for autism, and explaining to children the physical changes and puberty to a child who's autistic, that actually when you look through the principles could very much be used to explain the puberty and pubertal changes to a child who developmentally is a younger child. So although the child's not autistic, you could use those principles to emphasize that with your parents and the families to then help them explain that process to their child. In terms of other support or further support, you may potentially need to involve a clinical psychologist. And this really is to ensure that the child and family have appropriate coping strategies because of the significant impact on low self-esteem and coping with embarrassment about their bodies, not only the appearance, but also the functional changes in their bodies that are occurring that might be out of their control or that are out of their control. And also the emotional changes that happen with puberty, the psychologist can also help with that. It may also be a referral to manage parental anxiety. Think about whether or not the child needs the school to be aware. So practical suggestions. So if it's a girl and she's getting her periods, having the school teacher aware means that, there might be some sanitary pads available in the office that she knows are available, or, the permission for her to use staff toilets that have the right amenities. So practical changes, and also to make sure that the teacher sets reasonable expectations and isn't treating the child as older because they're taller or larger than the other children in the class, and that sort of perceptual understanding. You may need to involve the educational psychologist or school counsellor within the school setting if there are educational difficulties or behavioural concerns, and make sure you get a baseline cognitive assessment or other support in terms of their educational needs and ability to access the curriculum in the school. I put support groups or other parents and children there. I wasn't able to find any support groups, but I'm linking in again with the endocrinologists. I imagine they would have that information available. So that's one of the things I would have in my plan, but I didn't have, sorry, I couldn't put that in my slide. So all of the resources that I've talked about, again, I popped here as a list. So the growth charts, the AP booklet for children and families about puberty and its problems. I've also put 3 really useful articles. One is from the American Family Physician, so it's an American article, but I think really appropriate level for thinking about the red flags and an assessment of a child with early puberty. The American Academy of Paediatrics, and also a really useful article from the Archives of Diseases in Childhood, which is the UK journal for paediatrics. So, some 3 useful ones for further reading. And I popped all the websites for the Raising Children Network there. And thank you. That's it from me. I think I went over time, so I apologise. But yeah, I hope that was useful.
That was fantastically useful. Thank you so much, Melanie. I love that. It was very practical, and I really like the last bit too. That was particularly the stuff that hopefully as GPs we can step up and really help those kids cope with those changes, and we'll help the families cope with those changes.
Yeah, great.
What I didn't say at the beginning was there is an option to ask questions. So there is a little box there to pop your questions in. So if anybody's got any questions, please pop them in the box now, and we can ask Melanie while she's here. We can pick her brain. But while anyone's typing your question up, I guess I had a couple of questions I just wanted to ask you, Melanie, if that's okay. family history, so not necessarily precocious puberty, but it's just the age of the mum's menarche. Is that significant? How significant is that?
Yeah. I'll see. I'm sorry, I can't slide quickly through my. Let me just see if I go through. So in terms of family history, sorry. So I didn't go through in too much more detail the examination history, but I'll pop it up there in case you want to discuss it further. But definitely family history, I think, is important in terms of mum's age of menarche, because often, so from my understanding, in the girls that have idiopathic precocious puberty, often what you'll find is mum's menarche was also earlier, and don't hold me to it, but from what my reading was, just in terms of preparing for this talk, the progression is often not as rapid in these girls when mum's puberty was a little bit earlier. I think it's just an important question to sort of support, I guess, the diagnosis, but not as I think we know that sort of genetics has quite a big impact on our pubertal changes. So I think having a good understanding of that sort of family history also helps with sort of piecing together the puzzle. In terms of the family history, I think one of the interesting things is it's really hard to ask questions about dad's puberty. And so what I thought was really interesting is the age that dad reached his final adult height is one of the sort of useful markers for dad in terms of family history. So it's a bit hard to sort of, because a lot of the other changes are very sort of, I guess, not noticeable or not noted, but the dad's age when he reached final adult height would be one of the questions I ask in addition to mum's age of menarche.
Yeah, fantastic. And we've had one of the questions coming through about, you did mention about the expected time for girls to stop growing after they get their periods. What would we expect for boys?
Yeah. So I'll pull that chart up again. Sorry, I'm just trying to figure out how I coordinate my 3 screens. There we go.
Yeah.
So when I was running through here, I'll see if I can find it for boys. Okay, so off the top of my head, because I don't think I have it. So if you look at the growth velocity, this is the run for girls, and boys must be. So I'm probably making you dizzy with me flicking through so quickly. There it is. So this one on the left, you can see, you may not be able to see, but that's the growth velocity for boys. It's the bottom chart. And usually they stop growing around sort of 19, but it can be a little bit later. So probably, it's probably like 19, 20 is late normal for, like late normal range for boys. But you can see the 50th centile for that chart sort of ends almost at the end of that chart, which is about 18. But when I was speaking to my, as I said, the endocrinologist in my room, she said about 19, 20 years of age is late normal for boys to stop growing. Whereas girls, it's sort of 14 to 15.
Jane's asked, is there anything in the antenatal period, for example, maternal exposure or nutrition, that can affect the likelihood of developing premature pubertal changes?
Not that I found in my reading. I think you have to bear in mind, though, I guess, when you're seeing the changes. So one of the cases that that Zarina in my rooms mentioned to me was I guess a 4-month-old boy who presented with some mild acne, and then his growth velocity, if you looked at his growth, had rapid changes. I mean, in the end, he didn't have an exogenous course of the steroids. I think he had an adrenal tumor on one of his, adrenal glands. But it probably might be a question that I would ask. I think an important question that I would ask is, exposure for mum in pregnancy, just because I guess it's so close to that period. I always tend to ask for any child in that age group, when you're thinking about medications as a cause, if mum's breastfeeding, ask mum what medication she's on. You never know what's going to be transferred through the breast milk. Ask her what she's applying on her skin. For the girls with premature THELARCHE, for instance, they were linking, there's some studies that link it to things like, I'm not sure about soy, but one of the ones was lavender oil at some stage. Lavender in cosmetic products and things was being related to premature THELARCHE. So, you know, I guess that's an important question if mum's using lots of creams. I don't know, excessive amounts of creams with lavender oil. I don't know, but I think it's an important question because then you're going to be brainstorming with the endocrinologist if potentially that's a cause. But probably not for your 14-year-old. I don't think the antenatal history would be as relevant, yeah.
We're unfortunately running out of time, but there's a question asking about the opposite. So is there a common cause for delayed puberty in girls?
Yeah, good question. Common cause for delayed puberty. So I guess my thought in that would be really nutritional would be the main one. So, you know, I wouldn't say, I'm not sure if it's common, but I'm thinking when you're thinking about delayed puberty, whether or not that child's healthy, so chronic illness, whether or not they're underweight, and nutritionally if they're getting enough calories, and overall nutrition is being impacted on would be an important consideration for delayed puberty. And now that my brain's so stuck in early puberty, I'm having a brain freeze to think about other causes. But I think that was unfair. Yeah, no, that's okay. Get
you back to talk about delayed puberty.
Nutrition and weight would be, and obviously, you know, your young girls that are, you know, the elite athletes and things like that would be an important cause of maybe late normal puberty rather than delayed puberty. Yeah.
That's fantastic. So unfortunately, we've run out of time. I was just going to quickly mention health pathways and that there are a lot of resources on there, and I'm sure you're all very familiar with, or at least Sydney Health Pathways. If the username is connected and our password is healthcare, all the Southeast Sydney, of course, have different passwords which we can pass on to you if you don't know. There are an awful lot of things in there that you touched on, which is great. So development and growth, certainly accessing psychologists. And we're just about to put out some more healthy checks for children, so sort of based on the Blue stages that are hopefully going to be really helpful. But as I was listening to you tonight, I think I might have to have a chat to you, Melanie, about can we put a health pathway together on this subject, because I think it would be incredibly useful. And it's also shown me that we need to expand our growth pathways and perhaps put in a bit more about velocity and things and how useful those are, as well as the pubertal stages.
I didn't want to overwhelm you with the growth velocity, because I know like your access to previous records and previous growth measurements can be quite limited, and you're with the patient for such a limited amount of time. But I guess one of the things that I wanted to emphasize is definitely measure their height. And if you're going to see them in 3, 6, 12 months, you will yourself have access to the measurements, and just, you know, you can see on the chart the height centile if it's going off. You don't have to plot it on the growth velocity, but just understanding that to maintain that centile, you're growing usually on the 50th centile. But if you do plot their growth, you know, their height velocity to be above the 98th centile, that's accelerated, it's abnormal. And so, so I think it is useful to have that sort of understanding of how it links together.
That's certainly our take-home message, wasn't it? That really making sure that we look at the growth. So it is actually time's up, but if anybody wants to talk about and any other quick questions, because anyone is welcome to pop off, or we actually do have a question. Again, it's another big one. It's really about PCO and how we diagnosed PCO in girls or adolescents, and can be a bit tricky.
Yeah, I think you pushed me to my, I might have to defer that question to my gynae endo colleagues. So look, I have to say I'm not sure if it's a clinical or whether or not you would do blood tests and ultrasounds. But yeah, I mean, that would be something that I would be liaising with others in terms of expertise, in terms of diagnosis. But one thing I think really important from my perspective and from your perspective, in those, you know, those girls that are overweight, and those girls that do have premature adrenarche, you can make a difference to them later on, warning those parents about the risk of PCOS. And only just, you know, talking to my endocrinologist colleague, she mentioned that she saw these kids in clinic when they were younger, And then years later, she's seeing them in clinic for the new referral for PCOS. So, you know, later on, and or for being, you know, I guess overweight and the complications that come with that. So we can make a difference with those kids in terms of the trajectory of their health.
Sounds really important, doesn't it? And certainly the other questions, obviously you've hit the nail, because people are all asking for a copy of your slides. So I'm sure that would be all right to send the slides on. So yes, we've had lots of questions about that. And also a request for a child health check. So that might be something we get back to Bertha about. Once we get these pathways done, we might be able to present them as well. That might be a really useful one. So I'd really like to thank you so much for that. It really was incredibly practical, and it's exactly what we need in general practice. And thank you to everyone who's attended and all your questions. If there's any other pressing questions, please let us know. We can try and get an answer back to you. And of course, we will get your feedback. It's really important to you. It will be emailed to you, and so will a copy of the slides. So please hop online and get those done for us. And thank you so much, Melanie. It's been really, really helpful. Thank you.
Yeah, thanks very much.